Again, hello everyone. Welcome all participants and audience to the 33rd International Congress on Pediatrics. Here we are with you with the session of updates on liver failure in pediatrics. With the help of Texas Children's Hospital, Baylor College of Medicine, Houston, USA. I want to give a special thanks to dear Dr. Ayse Akcan, who helps us a lot in arranging and planning this session. I'm sure all of you will enjoy the session. I just want to play you the official sessional clip of this session. Then I'm going to be with you with introducing dear lecturers and facilitators. Thanks for watching. We are going to have an awesome session. Just for reminding, please keep your microphones off. Please keep your videos off, just in order to not interrupting their lectures. First of all, just let me make our dear lecturers co-host. First of all, we are going to be with dear Dr. Dalia Bashir. Here you are. Dear Dr. Dalia Bashir, graduated from University of Khartoum, Sudan in 2007. She passed the residency program at Penn State Hershey's Children's Hospital. She completed pediatric ICU fellowship and cardiac ICU fellowship at Texas Children's Hospital. Currently, she is an assistant professor of pediatrics at Texas Children's Hospital and works as faculty member in pediatric ICU and cardiac ICU. It is a big honor to having dear Dr. Dalia Bashir as the lecturer and also the first lecturer. Dr. Dalia Bashir, we are all ears.
All right, well, good morning, good afternoon, good evening, and thanks for having me as a speaker here at your conference. It's just such an honor to be part of this great group of physicians. What I'll do is I'll start by sharing my PowerPoint, if you'll just give me 1 second. All right, can everybody see my slides?
Yes, they're awesome. We are all ears with you.
Perfect, thank you very much. So what I will be talking about today is liver failure in the ICU. This segment will be, just to give an overview, will be divided into several segments by myself and my colleagues. The first one will be management of pre-transplant liver failure patients in the ICU. And then the second will be coagulopathy and pediatric liver failure by my colleague, Dr. Amir Navaiee. And followed by that will be hepatorenal syndrome by Dr. Ayse Arikan. And we will close it up with the postoperative care of liver transplant patients by Dr. Manpreet Virk. So the First part of the session, I'll talk about the pre-transplant management of liver failure in the ICU. I hope to cover the definition of acute on chronic liver failure in pediatrics, discuss the approach to the management of pediatric acute liver failure, review some ICU-specific challenges that we face, and then a brief overview of some of the established protocols that we have here at our institution. And just to open up, I'd like to just bring about 2 cases that we recently had in our ICU. The first one was a 3-week-old that presented with lethargy and poor feeding and had yellow discoloration of the skin and eyes. And his lab revealed elevated liver function tests with over 1,000 AST and ALT. His bilirubin was 20 with mostly conjugated hypobilirubinemia. His INR was 3.5. His fibrinogen was 129. His platelet count was 36,000 with a hemoglobin of 15. And his ammonia that was checked was 99 micromole per liter. The patient had undergone a bone marrow transplant, biopsy, that was concerning for hemophagocytic lymphohistiocytosis and was since transferred to our institution for liver failure management and transplant evaluation. He came to our ICU, was intubated on needing a lot of vasoactive support and was placed on renal replacement therapy and total plasma exchange and was later found to have HSV viremia. And unfortunately, the patient succumbed before he underwent a liver transplant. The second case is a 5-month-old who had a history of biliary atresia, whose status post failed Kasai, who's been living on TPN at home and being followed very closely with our hepatology team. He presented to our ICU with fever, lethargy, poor feeding, and irritability, and worsening abdominal distension. On exam, he was more irritable, more jaundiced, tachypnic with significant abdominal distension, and worsening liver function tests from his baseline. An ammonia that was checked was about 60, and his platelet count was 50, lower than his baseline, and bilirubin was higher. Blood cultures were positive for gram-negative rods from the central line. He was admitted to the ICU in septic shock and multiple organ failure, had a long course in the ICU, and eventually was transplanted. So the liver, as we know, is a vital organ and is tasked with multiple functions in the body. And it's the main source of our glucose storage and production, main source of our clotting factors and protein production. It serves as a site for our immune function, maintains our vascular tone, assists with digestion and bile synthesis and clearance. And if you think about it, and if any dysfunction occurs, we end up with hypoglycemia, clotting factors, deficiency result in bleeding and coagulopathy, loss of immune function and infection risks. We lose vascular tone and have hemodynamic instability, poor organ perfusion. With the bile clearance being affected with liver dysfunction, we have pruritus, we have some interference with drug function. We have inability to clear toxins, we have hyperammonemia and hypercytokinemia, and all of this ultimately will lead to multiple organ dysfunction. So how do we define acute liver failure in children? So acute liver failure is defined as an acute onset of liver injury without evidence of chronic liver disease and with an elevated PT or INR greater than 1.5 with evidence of hepatic encephalopathy, or an elevation of INR greater than 2 or PT greater than 20 with or without hepatic encephalopathy. And key is the coagulopathy is hepatic-based and not always corrected by vitamin K. Another form of liver failure is the acute on chronic. And these are patients who present with acute hepatic insult, manifesting as jaundice and coagulopathy, complicated within 4 weeks by ascites, encephalopathy in a patient who previously was diagnosed or sometimes undiagnosed with chronic liver disease, and they're associated with a higher 28-day mortality. And so why is it important to have a distinction between acute liver failure and acute on chronic? Well, acute liver failure patients, transplant is urgent, but they do have an ability to recover. Their transplant-free survival is about 55%. Their encephalopathy may be dramatic and INR may be high, but their bleeding risk may be lower. Their death is usually secondary to brain injury, and the trigger is usually hepatic necrosis. And it's difficult to predict their weight for recovery versus whether they'll get liver transplanted. And their post-operative course after their transplant is usually unremarkable. On the other side, the acute on chronic liver failure, transplant is essential, and this is the only way to get them out of this. And transplant-free survival is highly unlikely. the shock and coagulopathy and the renal failure can be quite dramatic, and they are very high risk for bleeding. Their death is usually from multiple organ failure, and it's difficult to stabilize them for liver transplant, and their post-op course can actually be quite dramatic. So what are some of the common etiologies of liver failure that we see in pediatrics? And what I'll represent is both national data and some of our data from our experience at Texas Children's. So Squires et al. Published data on about 1,000 children who presented with acute liver failure. And you will see that the vast majority, about 43%, are indeterminate. Some of these now qualify and are being looked at as a pathologic immune activation phenotype. Acetaminophen constitutes the next group of about 15%, and then metabolic disorders about 10%, which is different than the adult population, where acetaminophen certainly is the most common reason for acute liver failure. While the acute on chronic patients, as you'll see here, biliary atresia and idiopathic liver failure are usually the most common cause, followed very closely by infectious etiologies and metabolic. At our institution, from just looking at our liver transplanted population, we see that the vast majority were biliary atresia, constituting about 30% of the patients, and metabolic causes follow quite closely at 20%. And then acute liver failure is about 18%. So how do we work these patients up when they first come to the ICU? So we usually start out with just our basic labs. So reviewing the chemistry, so electrolytes, their renal function, looking at their liver function and liver enzymes, GGT, their bilirubin, albumin. We look at coagulation panels and see if there's anything that needs to be replaced. We look at the blood gas and specifically look at lactate and see how their ability to clear the lactate. We look at ammonia levels to help us with their need for any extra support. Blood counts, viral panels is some of the etiologies being viral hepatitis. We do toxicology screens, specifically looking at acetaminophen. And of course, we go through factor levels, clotting factor levels 5, 7, and 8 to help us distinguish between liver failure and patients who come in with DIC. They also undergo an HLH or hemophagocytic lymphohistiocytosis workup with ferritin and soluble IL-2 levels and NK cell function, just to ensure that we're not missing a genetic condition that could predispose them to HLH. And cancer workup, they undergo autoimmune panel and ceruloplasmin level to rule out Wilson's disease. So as you can imagine, with an organ like the liver that has a lot of organ crosstalk, the patients that present in liver failure to the ICU put us into a lot of challenges, and they pose a lot of challenge to the ICU physician. The hepatic encephalopathy, cirrhotic cardiomyopathy, respiratory failure, renal failure, and a hepatorenal syndrome, coagulopathy, infection risk, and with all of that, a paucity of organs to be able to transplant them and get them to the next stage. So our role as the ICU physician is to provide supportive care to all these organs, to treat any underlying causes if possible, and manage any complications that can arise, and get the patients in a state from which they can be transplanted. I'll review a little bit of some of the etiology-specific managements of acute liver failure that are more evidence-based. The most common one that we're all familiar with is acetaminophen toxicity. As we know with acetaminophen, the liver hepatic glutathione is depleted, and this results in hepatocellular injury, with central lobar hepatic necrosis being the pathognomonic finding on liver biopsy. Any dose of 10 grams per day or 150 milligrams per kilo per day is considered toxic dose. And usually the treatment is N-acetylcysteine, and that's the gold standard with a category 1 recommendation. We prefer IV over the PO route. And if the patient doesn't seem to be improving, we usually try to consider any co-ingestions as a possibility as well. Wilson's disease is another one that we see about 1 to 2 cases per year, and it's an autosomal recessive condition characterized by absent or reduced function of ATP protein, and that leads to decreased hepatocellular excretion of copper into the bile. And these patients present in fulminant liver failure, and high suspicion should be given when a teenager presents with anemia and elevated bilirubin and evidence of liver failure. And you'll find that they have low ceruloplasmin in the serum and high copper in serum and urine. Usually treatment can be extracorporeal support, chelators, and then eventually liver transplantation. Autoimmune hepatitis is a form of autoinflammation and injury characterized by the immune mechanism, and the diagnosed usually with liver biopsies and presence of positive autoantibodies. These patients usually respond to steroids and some immune suppression, and later considered for liver transplant if there's no improvement. Another form of acute liver failure that we see in the ICU that typically presents in the neonatal period is the neonatal hemochromatosis. It's also a form of allogenic immune response or gestational autoimmune liver disease. And it's characterized by very elevated INR, elevated bili, in the setting of normal or low normal AST and ALT levels. And it's usually mediated by IgG from maternal source. These patients usually undergo exchange transfusion and IVIG, and some, if they don't improve, undergo liver transplant. In the category that we talked about, the indeterminate category, which is becoming the more common cause of acute liver failure in the pediatric population, some are diagnosed with HLH or macrophage activation syndrome. And this is a form of pathologic immune activation as a secondary cause of HLH. And the primary form is a genetic mutation that presents usually early in the neonatal period. And if a patient comes in with the acute liver failure, it is prudent to ensure that they undergo bone marrow aspirate and consulting hematology oncology to rule out primary or secondary HLH, as the treatment for this is quite different and constitutes some steroids, immune suppression, or immune modulation. Other forms of acute liver failure that we see in the ICU commonly is actually ischemic hepatitis, or formerly known as shock liver. And this is poor perfusion that occurs to the liver and resulting in some liver damage. And this is usually worse if the patient already has pre-existing liver damage. And it usually resolves as soon as the patient's shock is improved. We'll see AST being a lot higher than ALT, and LDH levels are elevated as well. So as soon as the shock reverses, the liver injury reverses. Budd-Chiari syndrome presents with abdominal pain, ascites, and liver failure, and is characterized by portal venous clot. And we usually see this in hypercoagulable conditions like polycythemias or malignancies. So we try to manage these patients supportively, and if there is a specific antidote, we try to give that, like for Tylenol toxicity, we try N-acetylcysteine. But is there a role for N-acetylcysteine in non-Tylenol liver failure? This was, there was a randomized controlled study done in the adult population that in patients with acute liver failure who received N-acetylcysteine and placebo, compared to placebo in non-Tylenol ingestion liver failure. And what we see here, that it did not improve survival at 21 days. However, analysis of secondary outcomes revealed that there was improved liver transplant-free survival at 3 weeks for those who had hepatic encephalopathy. And similar findings were found in children less than 2 years of age. They were significantly less likely to survive with their native liver at 1 year if they had received N-acetylcysteine. So I'll touch on some of the specific things that we do in the ICU from an ICU standpoint once these patients make it to our unit. Until these patients either recover or receive a transplant, our role as the intensivist is to support the failing organs and to support the patient. So respiratory failure is one of the key presenting features. So these patients are usually on some supplemental oxygen, whether it's for shock or from the competitive abdomen. They do progress sometimes to needing endotracheal intubation and mechanical ventilation. They do sometimes undergo paracentesis and drainage of some of the acidic fluid, especially if it's interfering with our respiratory efforts. We try to maintain nutrition as best as we can. We try the enteral route, and if the patient does not tolerate, we transition the patient to total parenteral nutrition, being very careful to manage their dextrose. As we know, with liver failure, there's high chances of hypoglycemia. We also ensure adequate protein for both muscle mass and wound healing, but also being mindful of protein load in the setting of hyperammonemia. We try to balance their coagulopathy, and we try to should we try to target an INR, or should we just monitor them? Well, it's a big balancing game. And I think I'll skip this slide and allow Dr. Navaiee to go into details discussing coagulopathy in the liver failure patient. These patients also have evidence of vasodilatory shock when they make it to the ICU, and so they're started on vasoactive infusions. Usually, typically, we go to norepinephrine and vasopressin, and we stress them with hydrocortisone. We try some fluid boluses, but we try not to fluid overload them. One caveat to keep in mind is that vasopressor needs can worsen hepatic encephalopathy and can worsen our hepatorenal syndrome. And the need for vasopressors sometimes makes these patients poor candidates later for liver transplant. So the liver and the kidney have organ crosstalk is an important one to appreciate, and I'll leave this to Dr. Arikan to discuss in detail afterwards as well. But I'll touch a little bit on hepatic encephalopathy and why we should care about ammonia levels. Neurologic dysfunction is a big part of the ICU management of acute liver failure. Hepatic encephalopathy is a brain dysfunction caused by liver insufficiency, and it can manifest as a wide spectrum of neurologic manifestations, anything from just inconsolable crying to coma and herniation. And we can use different classifications or grading systems for hepatic encephalopathy, and we'll see anywhere from grade 1 to grade 4 using West Haven criteria or Glasgow Coma scale. So this is the West Haven grade 1 being trivial lack of awareness, just impaired performance, all the way up to coma is grade 4. And this is what we typically could use to also classify or characterize the hepatic encephalopathy in the pediatric population, excuse me. And you'll notice that we have some neurologic signs in this, reflexes, and also EEG changes that can be detected in the pediatric population. But ammonia is an essential mediator, but not the only mediator in this. As we can see, ammonia, glutamine, alpha aminobutyric acid, tryptophan, manganese, and opioids all contribute to the hepatic encephalopathy. So once these patients make it to our ICU, the key for us is to try to balance managing the high intracranial pressure and trying to get rid of the ammonia. So these patients are placed on lactulose and rifaximin to try to clear the pneumonia. We manage high ICP by sometimes needing to intubate and mechanically ventilate them to target carbon dioxide levels of 35 to 45. We try hypertonic saline and mannitol, barbiturates, and hypothermia, and trying to maintain cerebral perfusion pressure by raising our mean arterial pressure and keeping the head of the bed elevated. Some of these patients need ICP monitoring, and we have bolts or ICP monitors that can be placed in the ICU by our neurosurgical colleagues to help with managing and controlling our ICP. So with all of this in mind, medical therapy alone isn't always enough. We have to balance the fluid overload, the organ failures, the encephalopathy, the coagulopathy. And extracorporeal therapies have come to the forefront in ICU management of a lot of these complex patients that we see. So there are different extracorporeal support options are available, but when used alone, there hasn't been clear benefit. In our institution, we use a hybrid approach. And I'll talk about this a little bit. We use renal replacement therapy, total plasma exchange, and molecular adsorbent recirculating system as a liver support system. So we use our CRRT for our oliguric acute kidney injury or fluid overload, or to manage our hyperammonemia. And this is just high flux renal replacement therapy at a dose of about 3,000 mLs per 1.73 meters per hour clearance. We use total plasma exchange for patients who have hepatic encephalopathy or life-threatening coagulopathy or are about to undergo ABO-incompatible livers. And I'm sure Dr. Navaiee will talk a little bit more about the total plasma exchange. And we use a form of artificial liver support, the molecular adsorbent recirculating system, that consists of albumin hemodialyzer, a standard hemodialyzer, activated carbon adsorber, and an ion exchanger to help us with management of our hepatic encephalopathy and multiple organ failure that we see in our patients. So our indications to place these patients on extracorporeal liver support would be hepatic encephalopathy, any intoxications, multiple organ failure in the setting of liver failure, and cardiovascular failure, and needing renal replacement therapy as well. And our protocol is that this ELS is started in conjunction with renal replacement therapy, and it's done daily for 5 days in acute on chronic liver failure and daily for acute liver failure. We usually do about a minimum duration of about 6 hours, and then we do TPE additionally to that to manage any medically refractory coagulopathy. So we have actually published our data and looked at 15 patients who have acute liver failure and acute on chronic liver failure. 93% of them were ventilated and 80% were on vasoactive support. This was published by Dr. Arikan, who we're honored to have here with us today to present hepatorenal syndrome in just a little bit. And what we have shown is that our patient population who came in with acute liver failure and acute on chronic liver failure and underwent hybrid extracorporeal therapy with all 3 modalities of total plasma exchange, renal replacement therapy, and MARS. And you'll see here, out of the 15 patients, 13 got listed, 2 recovered before transplant, 9 were transplanted and all had survived, and 2 had passed away awaiting a liver transplant. Their 90-day survival post-transplant was about 100%, and overall hospital survival to discharge was about 73%. And you'll see that 87% had improvement in hepatic encephalopathy. And so this is our data before 2012. So this is patients who had liver failure and had only undergone CRRT. We had about a survival of about 40%. After 2012, we instituted CRRT and TPE. Our survival went up to about 50%. And in about 2014, we instituted our hybrid approach with CRT, TPE, and ELS. And you can see here that our survival had gone up about above 70%. And it takes a village. These patients are complex and require a lot of finesse in their care. And we have since noted that it's become necessary to create a dedicated ICU team to manage these complex liver failure patients. And so at our Texas Children's Hospital, we have our liver ICU team. And these are our colleagues who are part of our ICU team. And this is a multi-D approach. What we do is we round with the transplant team, the hepatology team, the dietitians, the pharmacists, the infectious disease, and try to bridge communication and concentrate on the experience to improve our outcomes. And with this, we've been able to standardize some rare and complex procedures, which include the hybrid approach and hybrid extracorporeal therapies, intracranial pressure monitoring, and protocolizing our AVO incompatible transplant, and also indications for any interventions that are warranted on these sick, complex patients. So with all that in mind, so what do the outcomes look like in pediatric acute liver failure? Well, there's spontaneous recovery in about 56%, and death in about 13%, and 31% undergo liver transplant. While acute on chronic, as we had mentioned earlier, have poorer outcomes, and short-term mortality, and their short-term outcome is poor at about 33% of these subjects. And if they have more than one organ failure, their outcomes are even worse. And the presence of AKI increases their poor outcomes by several folds. And just to touch on transplant, as you know, as medical technologies are advancing, there are more and more patients are currently waiting transplant. And you can see here, the demand is drastically outpacing the supply. You'll see that the top, I apologize, this one, the top is the patient's cumulative wait list patients are increasing, while the total transplanted patients has really not changed much. So in summary, the commonest cause of acute liver failure in pediatrics remains indeterminate, while biliary atresia is the commonest indication for liver transplantation. Hepatic encephalopathy is the most lethal complication in acute liver failure, and infections and coagulopathy are the cause of mortality in acute on chronic liver failure. Ammonia is a marker and a critical player in hepatic encephalopathy, but the levels don't always correlate with the degree of hepatic encephalopathy. And extracorporeal support can be safely used to bridge these patients to liver transplantation or recovery. And a dedicated liver ICU team as part of a multidisciplinary team may improve perioperative outcomes and management in these populations. I'd like to thank our Congress organizers. I'd like to thank Tehran University of Medical Sciences, Dr. Arikan, who's here with us, and Dr. Morris Fardasai, who's the director of our liver ICU team, and Dr. John Goss, who's our transplant surgeon, Dr. Lara Shkrinian, who's our boss here at Texas Children's. And with that, I will be happy to take any questions.
Many thanks, dear Dr. Bashir, for your wonderful presentation. We can't take out our eyes from. It was awesome. Thanks a lot for giving us your time and sharing with us your knowledge. Just before going to the any perhaps questions that we had, I want to introduce you the session facilitator, Professor Pejman Rohani, pediatric gastroenterologist. He is facilitator of this session, but we unfortunately didn't have the chance at the beginning of the session. I want to just introduce my dear Professor Rohani, and I pass the microphone to him for welcoming all the lecturers. No voice, just you have to unmute first. No. We don't have your voice still, Professor, so sorry for that. Yes, we have the voice now, dear Professor.
Do you have my voice?
Yes, here.
Okay. Thank you very much. Hello, Dr. Bashir. Thank you very much for your nice presentation. It was a fantastic presentation, and we learned a lot from you. Thank you very much for accepting our invitation. It's a great pleasure for us, and we are very, very happy that you accept our invitation, because it will be a great chance for us to collaborate in near future for your with your center, because we have a pediatric liver transplantation center in Tehran, and Children Medical Center, as you know, is the pediatric center of excellence in Tehran and in Iran. And we are very happy that if you accept our invitation to collaborate more about your experiences and sharing our experience with you, and new research in the near future with you in the area of pediatric liver transplantation. It was a fantastic, phenomenal speech. Thank you very much for your presentation. And please stay with us if you have time, because maybe some of our colleagues ask you a new question. Thank you very much.
Absolutely. Thank you very much for having me. It's such an honor. Absolutely looking forward to collaborating and doing some work. Thank you very much.
Thank you very much. Thank you very much.
Many thanks, dear Professor Rohani. It would be a great honor. And also many thanks again, dear Professor Bashir. Dear Professor Bashir, still we have no questions here in chat section, just many thanks. And they are telling that it was an awesome lecture. As I told you, we all enjoy it. So I think we are going to have you still up to the end of session, yes? So up to the end of session, if there is any question about your presentation, I will tell you. Again,
okay,
thanks a lot.
Absolutely. Thank you very much.
As the next speaker, we are going to be with Dr. Amir Navaiee. Sorry, just a bit. Yes. with Dr. Amir Navaiee, medical doctor. He is board certified in pediatric critical care and transfusion medicine. He is currently working as assistant professor in the pediatrics and pathology department at Texas Children's Hospital in Houston, Texas. His clinical and research interests are in bleeding and thrombotic complications of critically ill children, as well as extracorporeal technologies. He will be speaking on coagulopathy of liver failure. Dear Dr. Navaiee, it's a big honor to have you, and we are all ears with you.
Dear Dr. Ahangari, thank you so much. Greetings to everyone for participating in this great conference. It's an honor to participate. And با عرض سلام به تمام هموطنان عزیز. It's a great honor to participate here and be with you guys. And here I'm going to share my slide. Can you see my slides? All right. Okay, I'm going to talk about the coagulopathy in liver failure today. I do not have any conflicts of interest to report for this presentation. I'm going to try to cover this outline for my talk, and we're going to overview the coagulopathy in liver failure, talk about the stages of coagulopathy in liver failure, and talk about some of the laboratory diagnostic tests and considerations for management of the coagulopathy in liver failure. One of the major questions in liver failure is usually if the patients are hypocoagulable, balanced, or hypercoagulable. In the setting of liver failure, due to decreased synthetic function of liver, both procoagulants and anticoagulant factors decrease in balanced state, which will allow maintaining homeostasis. This is known as a rebalanced state in compensated liver failure. However, the severity of and type of the coagulopathy depends on the etiology and stages of the disease process. Factors such as factors 8 and von Willebrand are made also in the endothelium, and the setting of acute phase reaction can increase even though other factors that are primarily synthesized in liver would remain low. This will generate an unbalanced hypercoagulable state. Tripathi et al. In this study of by looking at the factor 8 to protein C ratios in cirrhotic patients showed that patients with more severe liver failure demonstrated by Child-Pugh score of A, B, and C, with C being the more severe disease, had higher factor 8 to protein C ratios, which make them more prone to be hypercoagulable. In our institution, we looked at the thrombin generation assay by using a special assay with a lower thromboplastin concentrate. And we evaluated liver failure patients. For those of you who are not familiar, the thrombin generation assay is mainly used for research, and it basically helps us understand the better evaluation of the overall thrombin generation capacity. In this graphs that you can see, the blue line represents the patient samples and the green line represents the control plasma samples. This is an example of a patient presenting with acute liver failure in the setting of acetaminophen toxicity. As you can see, the INR level initially starts from like 2.4 and gradually increases to up to 9.1. And then as the liver recovers, the INR goes back down to like 2.3. As Dr. Bashir also mentioned in her great talk, the INR, as we usually know it, as not reliable, and we're going to talk more about that in the subsequent slides. And in this graphs, you can see when we look at the thrombin generation potential, at the beginning, despite an elevated INR, the thrombin generation potential of the patient is actually much higher than the control plasma samples, which is a sign that they are actually more prothrombotic. And as the INR goes up, the liver severity of liver failure increases. We see that there's a decrease in the thrombin generation. And with the recovery, we see that also they go into a more prothrombotic state again. And basically, looking at the liver transplant patients, the Lisman et al. Performed a thrombin generation assay in different stages of liver transplant. And it was, they also demonstrated that intraoperatively, as expected during the reperfusion state, there's a decrease in the coagulation, thrombin generation capacity. And after the recovery by day 5, there's a significant increase, which actually make them more prothrombotic. And it's important to know because this is actually the time that usually there is an increased risk for thrombotic complications such as hepatic artery thrombosis. There is a smoldering disseminated intravascular coagulopathy in liver failure. And this is mainly characterized by elevated factor VIII and stable thrombocytopenia, which is caused by the increased endotoxemia and associated tissue factor release in liver failure patient. This happens more often in the moderate to severe chronic liver failure patients. And in addition to the ongoing smoldering DIC, and this terminology is basically used, accelerated intravascular coagulation and fibrinolysis for liver failure patients to distinguish it from the regular DIC that we see in the setting of septic shock or other severe injuries. Similarly, in liver failure patients, generally we see a stable D-dimer and coagulopathy in chronic patients, and in the acute and chronic liver failure with an additional insult of infection or any other tissue injury, we'll see that it's easy to push them into a full-blown DIC. Similar to other coagulation factors, fibrinolytic and anti-fibrinolytic factors are also in a balanced state. Fibrinolytic factors being plasminogen and tissue plasminogen activator, and anti-fibrinolytic factors being alpha-2 antiplasmin, histidine-rich glycoprotein, thrombin activatable fibrinolysis inhibitor, and plasminogen activator inhibitor 1. In more advanced liver failure, as the clearance for the TPA by liver decreases, we see an increase in the TPA in the plasma, and also further decrease in the anti-fibrinolytic factors. This is an example of a liver failure patient that we had in our institution, an 8-month-old with biliary atresia presenting with acute and chronic liver failure, developed diffuse mucocutaneous bleeding. And as you can see, the TPA concentration was significantly elevated. Plasmin-antiplasmin complex, which is a marker for the fibrinolysis, was also significantly increased with almost undetectable levels of plasmin activator inhibitor 1 activity, which demonstrates this balance very well. Also, in multiple studies, presence of fibrinolysis and liver failure was well described. And also we can see that in higher stages of liver failure, and the more severe the liver failure, the higher the incidence of hyperfibrinolysis, which can reach up to 75% of the patients. Hyperfibrinolysis also plays an important role intraoperatively during the liver transplantation. This graph demonstrates a different stages of liver transplantation, and also showing the TPA activity. And you can see that in stage 2, which is the unhepatic stage, there is an increase in the TPA as expected because there's no clearance. And this peaks up to the beginning of the reperfusion stage and gradually decreases over the 60 minutes after the transplantation. Now, how to assess the coagulopathy in liver failure? Routine coagulation studies such as PT, PTT lack sensitivity and won't account for the protein C activity due to the lack of thrombomodulin. And because of this, they are not able to detect the rebalanced state that we talked earlier. In this study by Tripathi et al., basically demonstrated in cirrhotic patients, while there is about 30% increase in PT and PTT ratios comparing to control, looking at their thrombin generation assay by using thrombomodulin, which activates the protein C and accounts for the protein C activity, actually showed there was no difference between their coagulable state and thrombin generation capacity between the cirrhotic patients and the control plasma. And there are some pitfalls with the PT-INR, as we discussed earlier. INR was originally developed to standardize the PT results due to variable thromboplastin reagents. And this was based on the patient samples from patients who are using warfarin, the vitamin K antagonists. And because of that, the INR that we currently use is not standardized for the liver failure. And that's why we see this discrepancy between the liver and the INR levels and the risk for bleeding. APTT also is insensitive to deficiencies of natural anticoagulants. It needs a significantly decreased amount before it can show a change, and also gets affected by lupus anticoagulant, C-reactive protein, antiphospholipid, the phospholipid binders, basically. That's why it is not unexpected to see a poor correlation of APTT with the clinical bleeding. INR shows significant variability between labs, and this is mainly, as we discussed, because of the thromboplastin reagents that they use. And this is, and we know that it has not been standardized so far for the liver failure patients because of the basically highly variable nature of liver failure patients. And in this study by Trotter et al. Basically demonstrated this change between different labs using the same cirrhotic plasma samples, and showing that how it can affect the clinical scoring system, such as MELT score, that can potentially affect our decisions about the patient. In some studies, INR was trying to be standardized for the liver failure patient by using the ISI for the liver and using the plasma samples from cirrhotic patients. Tripathi et al. In this study showed that basically the variability that we see between the labs will decrease when we use this ISI liver. However, this strategy was not being able to use in the clinical practice because of high heterogeneity in the liver failure population. Viscoelastic studies such as ROTEM and TEG on the other side provide a global assessment of coagulation by using whole blood. This graph demonstrates basically standard ROTEM output that we are currently using in our institution as well. There are some limitations with these studies as well. One of them being they're insensitive to mild to moderate platelet dysfunction and unable to detect the von Willebrand factor deficiency. However, they are able to provide a wide range of information from basically the adequacy of the coagulation factors by measuring the time to clot formation, as well as the strength of the clot, which is mainly affected by the fibrinogen, factor 13, and platelet concentration and activity. And this is an example of a patient that we had in our institution, and comparing the routine coagulation assays with the viscoelastometric assay and ROTEM in the case of our institution. As you can see, this patient has a high INR of 5.7, PTT is prolonged to 45, and the fibrinogen is slightly decreased to 177 milligram per deciliter. And when we look at the ROTEM study, INTEM is similar to PTT using similar reagents. XTEM is similar to PT, and FIPTEM is a study using an antiplatelet agent to remove the platelet function and looking at the fibrinogen function. As you can see, all of these studies are within the normal range, despite this patient had a very abnormal routine coagulation assay. And this is a good representation of the rebalanced state in liver failure patients. In our institution, we use ROTEM in liver failure patients to assess their coagulable state and basically decide about which INR level could potentially be a cutoff to transfuse patients. And obviously, as you know, the liver failure patients evolve frequently, so it is important to repeat it intermittently to reset the targets. And another advantage of ROTEM or TEG or viscoelastometric assays is basically demonstrating hyperfibrinolysis. As you can see in the graph, it was demonstrated by maximum lysis in ROTEM and lysis time in TEG, which we can detect the hyperfibrinolysis. Which is a big advantage comparing to routine coagulation assays. This is also a study that we performed in our institution, looking at the viscoelastometric assay and TGA thrombin generation assay in liver failure patients, and looking at the correlation with the bleeding episodes. And we were able to see that XTEM clotting time in ROTEM, as well as the thrombin generation assay, the lag time in the thrombin generation was significantly associated with the bleeding episodes, which is was a great finding, because there is actually paucity of data about what tests could be correlating with the bleeding episodes. Obviously, further testing, further studies needs to be done to establish this, but it was a good finding so far. And viscoelastometric studies was also used in the intraoperative management of the coagulopathy in liver failure patients, and was demonstrated that actually targeted therapy with the viscoelastometry was significantly reducing the amount of FFP transfusion in these patients. However, there was no difference in survival. Some of the considerations for management of coagulopathy in liver failure. We frequently use red blood cell transfusions, and it's always a debate whether what target we need to use for the hemoglobin. And this is not about the liver failure. This is a basically a North American registry for red blood cell transfusion intraoperatively. And we know that by this data and many other data that red cell transfusion is not necessarily benign. And this data clearly demonstrates that the increased perioperative red blood cell transfusion increases the odds of having thromboembolic complications. Therefore, we need to be judicious, especially we know that in liver failure patients, they are at a hypercoagulable state in certain times. Similarly, in an institutional study by Silva et al., looking at their 10-year experience, patients who had higher red cell and the FFP transfusion, a high volume red cell and FFP transfusion, they were having significantly higher rate of hepatic artery thrombosis as the thromboembolic complications. One of the main transfusion blood products that we use for transfusion in liver failure patients is plasma. And always the concern is that whether we are increasing the risk for thrombosis in these patients. As we discussed earlier, obviously high volume FFP may potentially increase the coagulable state. However, in this study by Tripathi et al., when they compared the a mixing study of cirrhotic patient plasma with the normal plasma, and looking at the thrombin generation assay, basically after mixing, despite showing that there is a decrease in the PT ratio, however, the thrombin generation potential was staying similar. And this is a testament to the fact that the plasma contains the adequate concentration of both procoagulant and anticoagulant factors and generates a balanced state for coagulation. So plasma is a safer option in the setting of liver failure, especially if you're worried about prothrombotic state. And another question is that what is the platelet threshold that we need to use? As you know, in liver failure patients, due to the increased portal vein pressures, there is a splenic sequestration and also activation of platelets. So there's a chronic thrombocytopenia. And this always becomes a question in the setting of surgical procedures. And in a study by, again, Tripathi et al., looking at the bleeding in the liver biopsy patients who had a platelet count of less than 60 had a significantly higher bleeding. And also another study by Seth et al. Looking at the thrombin generation in whole blood demonstrated that basically a platelet count of 56,000 per microliter was generating a normal 10th percentile of the normal healthy control patient. So it is a safe estimate to kind of say that for procedural aspect, a platelet count of 60 and above would be a good target to start with. And in the setting of liver failure, patients who have bleeding with the liver failure, the using of antifibrinotics have been studied. As we discussed, the fibrinolysis is a prominent factor in liver failure, especially in more advanced. And two of the antifibrinolytics, alpha-aminocaproic acid and TXA, tranexamic acid, have been studied in liver failure. And it was more studied in the setting of the liver transplantation. In this study, they looked at the cirrhotic patients with shortened euglobulin lysis time. This is an older test that has been used to demonstrate fibrinolysis. It was demonstrated that there was no thrombotic complications, and there was an improvement in resolution of bleeding in this patient. About 92% of patients who had bleeding had resolution. So it's important to know that this is an option that we can use in advanced liver failure when they have significant bleeding. Tranexamic acid was studied in the setting of intraoperative use for the liver transplant patient. And a systematic review and a meta-analysis of the RCTs did not find any major difference in respect to venous thromboembolic complications, hepatic artery thrombosis, or perioperative mortality. However, all of these studies were underpowered. Cochrane systematic review found no significant difference: 60-day mortality, primary graft function, and retransplantation of thromboembolic episodes between TXA and placebo. These are all good findings regarding the safety of the TXA. However, we need to be also judicious about using this, considering all the risks for hyperthrombotic, prothrombotic state in these patients. Prothrombin complex concentrate with the commercial name going as K-Centra. It might be different names in different countries. This is also a factor concentrate of that is FDA approved for the vitamin K antagonist reversal. Similar to FFB, it has a good basically effect of the INR correction. It has the advantage of having the lower volume. However, there is no standardized dosage for liver failure. Mainly the dosage is basically for the warfarin reversal. In this study by Tischendorf et al. Demonstrated that basically using the PCC at a higher higher dosage, there was an increased risk of thromboembolic complications. So this is important to consider. The doses that they use are significantly higher than what we would typically use. Other studies showed that the dosage of about like 20 per kilo has been safe. For the sake of time, I was not able to show all the studies here, but this is something to consider. So basically, though there is a dosage-dependent increase in thromboembolic complications, that's an important factor to consider. Recombinant activator factor 7 is also well studied in the setting of liver failure. There are 2 RCD studies showed no advantage in mortality and bleeding control in GI bleeding, and 2 RCD studies show no significant difference in perioperative red blood cell requirement in liver transplant. And there was, again, dose-related increase in the arterial thromboembolic event. So it is a drug that needs to be used judiciously, mainly for like as a last resort when there's poor bleeding control, knowing that it may increase the risk for thromboembolic complications. Therapeutic plasma exchange is another method of extracorporeal support system for liver failure patients. And there are different categories that can apply to these patients. As for category 1 and the acute liver failure for coagulopathy reset, and also as for category 3 in the setting of sepsis and multi-organ dysfunction. And the coagulopathy can be improved with the therapeutic plasma exchange. However, there are scarcity of data regarding the treatment regimen and outcomes. There is a question of the data is also scarce about the possible benefit for the survival in these patients. As a summary, these asymmetric studies show better correlation with bleeding and can help with improved target-based transfusion. Transfusion support with plasma may provide a more balanced coagulation profile if the patient can tolerate volume. Consideration of utilizing antifibrinolytics in the setting of life-threatening bleeding, and if volume is an issue and prothrombin complex concentrates are being used in the liver failure, it needs to be used judiciously, and it's better to use in lower doses at the beginning and follow closely for thrombotic complications. And thank you again for having me, and this was a great pleasure and honor. And I am happy to answer any questions.
Many thanks, dear Professor Navaiee. It was so nice. It was awesome. I just was thinking about where the technology is leading us as a doctor, as a normal person. It is really exciting to see that the technology, how is helping people, how is helping doctors, and so on. Thanks a lot for sharing your knowledge with us. If you have any question, I'm gonna sharing with you up to the end of this session. Again, many thanks for your awesome lecture.
Thank you, Dr. Hangari. Thank you. Pleasure.
You're welcome. As next, we are going to have dear Professor Dr. Ayse Akcan Arikan, my dear professor, with us. Dr. Akcan Arikan received her degree on Fellowship of Pediatric Critical Care from Baylor College of Medicine, Houston, Texas, United States, at on 2004, and also Fellowship of Pediatric Nephrology from Baylor College of Medicine, Houston, Texas, United States, 2012. She's an associated professor of pediatrics critical care at Baylor College of Medicine, Houston, Texas, and she is also associated professor of pediatrics renal and critical care section at Texas Children's Hospital. It is a big honor to have dear Dr. Akcan with us. It's a big pleasure. The seat is you, and we are all ears with you, dear professor.
Thank you very much. It's always such a treat to come back to you guys. Thank you for the invitation. It's the only conference where my name is accurately and correctly pronounced, because everybody else makes things up as they're introducing me. İyi akşamlar to everybody who is joining us from a different time zone. It's morning here, hence the glare behind me. I apologize for that, but I can't really control daylight, unfortunately. Let me share my screen and then we'll get started. I have the privilege of talking about hepatorenal syndrome today, which is, you're going to see that there's going to be tons of adult data. Unfortunately, the data in pediatrics is incredibly limited. And I took the liberty of combining things and injecting some of my personal experience into it. So hopefully, wherever possible, I've indicated the references for you if you needed to look up. I also shared my presentation as PDF with the conference organizers if you wanted to look through them. There's not going to be much text. There's going to be a lot of figures and then a few pointers that we're going to get into. What are we going to do today? We're going to talk about the definition, because the definition of hepatorenal syndrome has changed recently, and talk a little bit about epidemiology, not much, because not much is known in pediatrics, but spend the bulk of our time about the pathophysiology and learn about cirrhotic cardiomyopathy, which is a better established concept in adults, but we are learning the importance of it in pediatrics, definitely from data coming from our center. And then visit inflammation as an augmenter of this pathophysiological interaction. Talk a little bit about the differential diagnosis, not much, and touch on management and talk about the unique challenges in pediatrics. But it will mostly be pathophysiology and definition. So you heard from Dr. Bashir, liver failure is the perfect model for multiple organ failure because of organ crosstalk and the multifaceted functionality of liver. Just the failure of one organ is enough to trigger organ failure in multiple other organs. And because of that, in whether it's acute liver failure or acute on chronic liver failure, as you've heard a while ago, it is very common that advanced liver failure in the ICU looks like this, with multiple machines surrounding a baby. And believe it or not, there's actually a baby in the background right there. So the management of it is very complicated when multiple organ failure sets in, and kidney dysfunction specifically seems to have a heightened role in this organ crosstalk. So let's talk about the two concepts of acute liver failure and acute on chronic liver failure. You'll see that traditionally decompensated cirrhosis, then decompensated cirrhosis, then acute on chronic liver failure was conceptualized as a spectrum, chronological spectrum. When kidney injury happens in decompensated cirrhosis or acute on chronic liver failure, this is all data from adults. About half of the patients need to be admitted due to their worsening status. It has a terrible prognosis with 50% mortality. And even if they don't develop hepatorenal syndrome initially, eventually they'll develop hepatorenal syndrome, and hepatorenal syndrome has a high mortality. And until recently, didn't really have a targeted management option. Acute liver failure is very different though, because of the underlying disease heterogeneity, especially in pediatrics. It could be hepatitis, autoimmune, or unknown, or this inflammation mediated HLH-like phenotype, and the underlying disease process is going to present with differing kidney involvement. in adults in acute liver failure, when patients develop acute kidney injury, if it is advanced, termed stage 3, there is a 50% mortality. And the use of renal replacement therapy is much more frequent in acute liver failure for one reason or another from different indications. One thing that I would like you to learn from this talk today is that AKI in liver failure patients is not hepatorenal syndrome. And that's what we're going to spend the next few minutes on, unpacking the definition, what's in it in AKI and AKI-HRS. So acute kidney injury traditionally is acute, right? It is defined by a sudden and precipitous decline in kidney function. Usually there is a time window associated with it. The most current consensus criteria, which is the Kidney Disease Improving Global Outcomes, KDIGO criteria, stipulate 48 hours to 7 days for this acute dysfunction or acute decline in glomerular filtration rate to happen. But then we all recognize that not all patients follow that paradigm, and patients can actually have onset of dysfunction over a longer period of time and might not completely resolve. So the old terminology was to call everything related to acute kidney injury in liver failure hepatorenal syndrome, and define it in or divide it into type 1 and type 2, which were really very poorly delineated. They didn't really differentiate from each other very well. New terminology introduces hepatorenal syndrome AKI, HRS AKI, and non-HRS AKI. And we're going to understand what we mean by that when we get into pathophysiology. That is the acute setting, when it actually does not resolve or does not have the 7-day onset as we are looking for, then it gets into this chronic phase. And if it is HRS, then it could be HRS non-AKI, or if it is non-HRS, it is straightforward chronic kidney disease. Now, persistent disease that persists for up to 3 months from HRS, which is called HRS acute kidney disease, HRS AKD. If it persists beyond 90 days, 3 months, then it's called HRS CKD. Let's learn about serum creatinine and its shortcomings in liver failure. So creatine is made in the liver, okay? So in advanced liver disease, the upstream product of creatinine is produced at a lower rate. In addition to that, there is a large volume of distribution, especially in patients who have cirrhosis. Bilirubin, depending on what assay the lab is using, could interfere with serum creatinine measurement and might mask increases in serum creatinine. It's not common in the enzymatic method, but in the old methods, this was a well-recognized limitation. Liver synthetic function, we talked about, it might be decreased up to 50% creatine production. In addition to that, patients who are chronically ill typically have malnutrition, especially protein malnutrition, and have lower muscle mass, where the creatinine is coming from, as you guys know. And the baseline range for creatinine, because of these issues, should really be much lower than what's considered normal in the laboratory normal windows, normatives that are reported from the laboratories. Because of this, because of the extra-renal factors that play into serum creatinine levels, cirrhotic patients, when they have a given change in GFR, they have a much smaller magnitude and further delayed change in serum creatinine. Serum creatinine already lags behind an insult by about 36 to 48 hours due to the way creatinine is handled in the tubules. But in cirrhotic patients, this could be even later. What is the consequence of that? It delays access to timely treatment and has prognostic implications. Gender is important, especially in adults. Women have lower serum creatinine despite similar measured GFR. There is different filtration molecules, such as cystatin C, that we have started to use increasingly more in clinical practice recently. So that might be a better gender neutral filtration marker, but it's not widely available and it's very expensive compared to serum creatinine. In our patient population, where we use the PELD score for transplant prioritization, because serum creatinine is included in PELD and also MELD for anybody who is 16 years and older, it disenfranchises them for transplant allocation, especially women. But the pediatric definitions for it are largely driven from adults, and we don't really have specific pediatric concentrations built into acute kidney injury or kidney disease and liver failure. What are the causes of liver failure related acute kidney injury? So the hepatorenal syndrome is the topic, but I want you to understand that there is so much more that comes into play in this presentation. The most frequent being what we used to call prerenal, which we now call functional, hypovolemia associated acute kidney injury. This could be GI bleeding, GI fluid losses related to diarrhea, lactulose use, vomiting, and many cirrhotic patients, when they develop decompensated cirrhosis, are treated with diuretics. So diuretic use, maybe a little overuse, could actually lead to a volume responsive state and create functional AKI. Another very common occurrence, especially in our smaller patients who have significant organomegaly and large volume ascites, is intra-abdominal hypertension, which we're going to spend a moment on in a minute. Many of these patients we treat in the ICU especially are exposed to nephrotoxic medications, specifically antibiotics, right? Because inflammation and translocation-related infection is common in these patients. So drug-related kidney injury is a very common occurrence. And hepatorenal syndrome is, yes, a diagnosis of exclusion as it is traditionally taught, but also it's so much less common and sometimes very, very difficult to differentiate in the clinical setting. Is it just hepatorenal syndrome, or is there something else that is also playing a role? AKI in liver failure, whether it is acute or chronic, ALF or ACLF, is a bit unique in our approach to it. Differential diagnosis is also is somewhat goes hand in hand with intervention. So in order to tease out whether we actually have a volume responsive state, we do need to stop diuretics and maybe volume resuscitate a patient and differentiate it from hypovolemia versus shock. Shock will also behave as if it's a volume responsive state sometimes, especially if the effective circulating volume is decreased with venodilatation. We need to differentiate whether there is a toxic arm involved. It could be nephrotoxins, but recently we've come to understand the importance of very high bilirubin and bile CAS in the propagation of kidney injury in liver failure. Could it be infectious? And infectious could be sepsis, as these patients are immune suppressed. You heard from Dr. Bashir. Or is it a localized infection? Do many of them develop spontaneous bacterial peritonitis? And abdominal infections propagate kidney injury much more because of the geographical adjacentness of the infectious source and the kidneys. Or is it parenchymal disease? And if parenchymal disease is ruled out, is it hepatorenal syndrome, which has a pretty dedicated, different approach in terms of management. So International Club of Ascites recently came out with a consensus statement that said we do need to base AKI diagnosis in HRS AKI on the KDIGO criteria that are used in non-liver failure patients to define AKI. So here are the things that need to be present. The patients need to have a cirrhosis, acute on chronic liver failure or acute liver failure. Then this increase of 0.3 within 48 hours or 50% increase from baseline within 7 days is the KDIGO definition. Or patients are oliguric, less than 0.5 milliliters per kilo per ideal body weight for at least 6 hours or longer. Then we come to the therapeutic trial part of the differential diagnosis, diuretic withdrawal and volume loading, and whether there is response to it. But then there is the other differential diagnosis that needs to come into play, where the diagnosis of exclusion part of it happens, We need to make sure there is no shock, there is no nephrotoxic drug exposure, there is no parenchymal disease indicated by proteinuria, hematuria, if available, urinary injury biomarkers, which I'm going to show you some adult data on, or an abnormal kidney ultrasound, and a very, very low fraction of sodium, not the less than 1% that we typically teach for hypovolemic state, but less than 0.2%, even 0.1%. And then the stipulation for the HRS-AKI is time. So if this dysfunction happens within 48 hours or within 7 days, and in a short period of time, then it is HRS-AKI, and it fits in the acute part of that paradigm. What is most important, because of the serum creatinine impact that is a direct result of the underlying liver disease that we talked about with the volume of distribution and decreased creatine production, is the baseline serum creatinine. So this is how baseline serum creatinine is defined. The serum creatinine obtained in the previous 3 months, and if that's not available, the lowest one, the value closest to admission. And if that is not available, the serum creatinine on admission should be used as baseline. What are they trying to say here? They're saying the patient's normal serum creatinine is likely way lower than what is the normal lowest limit of the normal window that your laboratory is reporting. Say a 16-year-old who presents with a creatinine of 0.9, even though it might actually be normal as the laboratory window, might have a baseline creatinine of only 0.4 and would qualify as AKI on presentation. So we need to be aware of the patient's previous creatinine baseline to understand where their own levels live. However, as you know, especially with acute liver failure, it's not always possible to have previous values. Sometimes some investigators, some clinicians have used after the admission, the lowest creatinine that's available throughout the admission to indicate the baseline to make a retrospective diagnosis. Regardless, baseline matters. So HRS-AKI is within a short period of time. How about HRS with a chronic paradigm? Let's go back for a minute and think through that. HRS-AKD and HRS-CKD are both prolonged kidney dysfunction. One is shorter than 3 months or 90 days, AKD, and the other one is traditional CKD, which is longer than 3 months or longer than 90 days. Both of these conditions are termed as HRS non-AKI, and they're not really the topic of our discussion today, although sometimes, especially patients who come from poor follow-up previous to their hospitalization with decompensation, it might be very difficult to tease out whether this is true HRS-AKI or it's a part of HRS-AKD that has not resolved. Something that needs to be kept in mind when approaching patients in terms of their treatment response, etc. I'm going to just spend a moment and show you something. This is really more adult data than anything, but acute and chronic liver failure has very high mortality in adults. And that's the reason the adult physicians are trying to make a distinction between decompensated liver disease and acute and chronic liver failure. I'm showing you that the 28-day mortality and the 90-day mortality for patients who have ACLF is much higher than the patients who don't have ACLF, and the staging of it, even with kidney disease, patients qualify for multiple organ failure, even though they might not really have multiple organ failure in the true sense of the term. So a liver failure combined with kidney failure qualifies as acute on chronic liver failure for adult patients, increases their mortality and their prognosis, especially transplant-free survival rates decrease. Therefore, the understanding of kidney disease in liver failure has significant implications in terms of prognosis. The last graph on the upper right-hand corner is showing you that throughout the course of the patient's disease, or throughout their admission, their profile might change. They might present with ACLF stage 1, but they could progress over time to stage 2 and stage 3. If they present with stage 3, they mostly stay as stage 3. So it's a dynamic process and requires frequent assessments. This is much less understood in pediatrics, but we're beginning to understand that there is a lot of organ crosstalk that is similar in pediatric patients that replicates some of the adult data, especially in the cardiac, kidney, and renal, cardiac, kidney, and liver link. So the typical pathophysiology is when we have cirrhosis, the obstruction to portal flow creating splanchnic vasodilatation. This could happen through hydrostatic pressure changes with portal inflow increasing and portal hypertension creating backflow into the splanchnic circulation, but also it is mediated through vasodilators and angiogenesis that happens in the mesentery with abnormal response to vasoconstrictors. The splanchnic vasodilatation with spillover of mediators into the systemic circulation leads to systemic arterial vasodilatation, which effectively decreases the circulating blood volume, leads to the compensation of renin, angiotensin, aldosterone system, the sympathetic nervous system, and the non-osmotic release of angiotensin, vasopressin, I apologize. And the renal circulation itself, intrarenal circulation, actually has increased sensitivity to circulating vasoconstrictors, leads to altered renal autoregulation, which then after progression of the disease stops being compensation and starts becoming kidney disease. We're going to unpack that in a minute, step by step, but I'm going to remind our audience that pre-ascites liver disease is still a sodium retention, sodium avid state for the kidney when the ascites is developing. When there's obvious sodium retention, ascites develops, it's typically termed diuretic responsive. When the refractory ascites, diuretic refractory ascites develops, typically we have significant sodium retention, but also change in volume of distribution, which manifests itself as hyponatremia. And then the autoregulation loss and other factors come into play as hepatorenal syndrome. This is an older slide, as you see. It's talking about HRS type 1 and 2. We're now calling them HRS AKI and non-AKI. Further illustration here that there is a hemodynamic component that is driven by vasodilatation and decreased circulating blood volume, which over time turns into full-blown renal failure. The reason HRS has been called functional renal failure is because over many decades ago, the observation was made that with liver transplantation, the kidney failure that was observed in advanced liver disease was completely reversible. Even though the functional renal failure terminology comes from that concept, we now understand it a little bit better with the changes in circulation that we're going to visit in a minute. So in hepatorenal syndrome, vasomotor changes are driven by this splanchnic vasodilatation and the decrease in effective circulating volume. However, now we understand that there is two more legs, if you will, to this tripod. One is cirrhotic cardiomyopathy, the other one is systemic inflammation. And multiple factors come into play to present the patient in hepatorenal syndrome. And our understanding of these two foundational pillars of the pathophysiology is instrumental to managing these patients better. The renal blood flow, we talked about splanchnic vasodilatation, but I want to highlight that the intrarenal blood flow is also maldistributed in hepatorenal syndrome. In fact, there is intense cortical vasoconstriction that happens, which is really the metabolically most important part of the kidney in terms of really filtering and processing and detoxifying. And the vasoconstriction in adults could actually be detected by non-invasive methodology using resistive indices on Doppler ultrasound. This has never been studied in children and never really been studied in a rigorous fashion in even young adults. This is an older adult data, but it is possible to actually demonstrate the intense intrarenal increase in vascular resistance resulting from vasoconstriction using Doppler resistive indices. But what actually also happens over time, in addition to the systemic vascular resistance decreasing and the arterial resistance in the kidney increasing, is the decrease in cardiac output. On top of that, renal autoregulation that normally is our savior, despite a wide range of changes in renal perfusion pressure, the renal blood flow is maintained in a very tightly controlled window. In hepatorenal syndrome, this curve is lost and it shifts to the right, meaning we need to have a higher renal perfusion pressure in order to be able to maintain the same amount of renal blood flow. Or renal blood flow decrease leads to a more exaggerated decrease in renal perfusion pressure. And this is a progressive phenomenon from pre-acidic liver disease to diuretic unresponsive to hepatorenal syndrome, but does not have to follow these steps with a trigger. Pre-acidic or diuretic responsive ascites could easily turn into hepatorenal syndrome. Typically, that trigger is infectious. Now let's talk about cirrhotic cardiomyopathy a little bit and explain what that means. So it's a three-pronged process that is seen in patients with pretty significant cirrhosis, and typically in patients who have cholestasis. It's a blunted contractile responsiveness to stress, so systolic dysfunction. The diastolic relaxation is altered, so there's diastolic dysfunction. There is also electromechanical abnormalities, electrophysiological abnormalities that can be picked up on EKG with abnormal conduction intervals. So the inappropriate cardiovascular response to endotoxemia or any stress is really the hallmark of cirrhotic cardiomyopathy. And there is a lot of preclinical data that explain this phenomenon to us. There is changes in the receptor types on cardiomyocytes with decreased beta adrenergic receptors and increased cardiodepressive receptors, cannabinoid receptors, alteration in calcium and potassium channels, which you'll remember are very instrumental in contractility, which lead to systolic dysfunction and diastolic dysfunction. And the electromechanical abnormalities, specifically prolonged QTC, could actually lead to life-threatening abnormalities. Now, adult data show that in adult cirrhotics undergoing liver transplant, 50% of the patients have cirrhotic cardiomyopathy with arrhythmias and sudden death potentially resulting from prolonged QTC. It actually plays into hepatorenal syndrome, especially with an infection trigger. Post-liver transplant mortality is also increased in patients who go into transplantation with cirrhotic cardiomyopathy. It contributes to decreased quality of life. It is reversible, but only after liver transplantation, and doesn't really have dedicated treatment options. The only thing that I would like to highlight from this slide is that adrenal insufficiency, which you heard from Dr. Bashir, common in cirrhotics, even in pediatric patients, might actually also worsen cirrhotic cardiomyopathy, potentially because of its impact on further decreasing of adrenergic receptors and modulating the catecholamine effect. The myocardium in cirrhotics who have cardiomyopathy, does not mount a tachycardic appropriate increased cardiac output response to stress. And this is augmented by adrenal insufficiency and could actually compound the presentation of non-HRS AKI. In pediatric patients, this is Dr. Desai, who leads our liver ICU group at Texas Children's Hospital. This is his data. He showed in biliary atresia patients, which is the prototypical cholestatic disease in pediatrics, the frequency of structural and functional defects were 30%, 30%, and functional defects alone was 12%. And these patients all had increased ICU length of stays before the liver transplantation and after the liver transplantation. In another look at a later cohort, again from our institution, his group showed that pre-liver transplantation requirement for liver support was much higher in patients who had cirrhotic cardiomyopathy, and post-liver transplantation, a lot of these patients went on to require further life support, such as prolonged mechanical ventilation and CRRT. I'm going to skip this and just say the perfusion pressure is also impacted by intra-abdominal hypertension, which is augmented in patients who are on positive pressure ventilation, and it will be very difficult to diagnose unless we actually suspect it. We don't really know what the intra-abdominal hypertension threshold is. The normal blood intra-abdominal pressure is thought to be in the single digits. There is different thresholds that are thrown out there at 15 centimeters, 20 centimeters of water. In adults with intra-abdominal pressure greater than 20, increased urine output was obtained, which suggested improved kidney function with paracentesis. But one thing that we need to keep in mind is, especially when we do large volume paracentesis, that could precipitate hypovolemia, which can worsen kidney function with either functional pathophysiology or hepatorenal syndrome augmentation. So albumin replacement for large volume paracentesis is recommended. The adult data is listed there or shown there for your convenience, but we don't really know what the actual exact volume for large volume paracentesis correction in pediatrics should be. A word of caution for loop diuretics is that the loop diuretics augment and can tip over the compensation mechanism that is normally triggered in cirrhotic states with renin-angiotensin-aldosterone system, which then leads to sodium retention. Loop diuretics prevent the sodium retention, but could precipitate arterial underfilling and further augment through direct effect renin and angiotensin-aldosterone secretion, worsening this vicious cycle. So typically the first step in management of suspected hepatorenal syndrome or any AKI in advanced liver disease is withdrawal of diuretics. Now, the liver itself is an inflammatory organ, and when it is injured, there's a lot of damage-associated molecular patterns, chemokines, inflammatory mediators that are spilled from the liver into the circulation. And in addition to that, which triggers systemic inflammation, there is increased intestinal permeability due to changes in splanchnic perfusion. There is evidence in adults that shows that dysbiosis happens in advanced liver disease with a change in microbiome. And then the cirrhosis associated immune dysfunction compound all of this, making inflammation the other foundational pillar for presentation with hepatorenal syndrome or HRS-AKI. It's not only the direct bacterial products that translocate from the gut, but also the injured and dying organ propagating inflammation in its contribution to hepatorenal syndrome, which then could lead to release of oxidative organs, mediators that propagate oxidative and inflammatory injury, which further worsen the hemodynamic instability that is localized to initially to the splanchnic circulation. This is partially the reason why CRP and white cell count are almost always predictors of adverse outcomes in any classification mechanism used in chronic liver failure in adults. The data in pediatrics is not as clear. One word about differentiating hepatorenal syndrome from ATN. This is fractional excretion of sodium I'm showing you. As you see, compared to ATN and pre-renal azotemia or functional hypovolemic AKI, HRS presents with significantly lower fractional excretion of sodium, doesn't have as much albuminuria as ATI would have or ATN would have. And fractional excretion of urea is the same, less than 20% in a patient where that doesn't have other obvious risk factors could be assumed to have HRS AKI. Now, there is other tissue markers that might be available in certain centers. We don't use them, but one of these is Engel. So there is a signal, an uptick in HRS compared to ATN. It's much lower, but still it's higher than functional AKI, suggesting that HRS actually has some parenchymal involvement, contrary to traditional belief. However, these biomarkers are not readily available, and they don't really differentiate 100% of the time, and they're quite expensive. So their use in clinical practice is undetermined as of now. One additional word that I'd like to highlight is the presence of bile cast nephropathy, which we're beginning to understand the importance of much better with some biopsy data, with some tissue diagnosis that come from adults. In fact, 85% of the HRS AKI patients had bile cast in this case series, and high bilirubin is a marker for non-responsiveness to vasoconstrictors. So perhaps another pathophysiology is the mediator for the presentation that we see in refractory HRS AKI. So I hope I was able to explain to you that this is a spectrum, non-HRS AKI and HRS AKI, when you see these patients in clinical practice, and the differential diagnosis is going to be part of the treatment regimen. So once we actually diagnose these patients and stage AKI using KDIGO criteria, then we're going to try and differentiate the types of AKI by excluding obvious things, stopping diuretics, volume repleting, and then if there is no response to volume repleting, trying vasoconstrictors such as terlipressin, noradrenaline, or norepinephrine, or octreotide midodrine combination with albumin loading to assess if there is a response and reversal of renal dysfunction. If there is, then that is HRS AKI. So it's an interesting phenomenon where the disease treatment itself helps in differential diagnosis. There is no consensus definition of pediatric hepatorenal syndrome. We use criteria and definitions from adults extrapolated, but this is a very good, overwhelming, but worth to spend some time on your own figure from Dr. Akashdeep's fantastic article in Pediatric Nephrology from 2007, where he puts all of the pathophysiological mechanisms and pathways that I tried to summarize together to explain the complicated interplay between kidney disease and liver disease in pediatrics in advanced liver disease. These are not new concepts from even in the distant past. We have understood that the management of and the response to treatment of the patient is going to lead us on the diagnostic pathway, but it's worth visiting them with the new diagnostic terminology. And the takeaway points as I wrap up way later than I should is the baseline creatinine matters, so try and get that whenever possible for your patients. Timeline is important. Did it happen within 7 days, 30 days, 90 days, over 90 days in order to use the correct terminology? Here's a tongue twister. AKI is not HRS, but all HRS is AKI. So I'll leave you to think through that for a little bit. Differential diagnosis is part of the management. Management is part of differential diagnosis. Creatinine might not be best marker, but that's all what most places have. We use cystatin C. HRS is not purely functional, might not be completely reversible. Hemodynamics changes are not just in the kidney. Cardiomyopathy plays a role, so just volume loading might not be enough. Inflammation is key, especially in advanced liver disease in all forms of AKI. Pediatric data are scarce, so this is a good opportunity for you guys to generate your own data from the Liver Transplant Center, because we have very limited information from global sources. And with that, I am going to wrap up the whiz of hepatorenal syndrome review in pediatric AKI and turn it over to the mediators to see if there's any questions. Stop sharing now.
Many thanks, dear Professor Akcan. Your lecture was awesome. You know that kidney is complex, liver is complex, hepatorenal is much more complex, but you showed us how beautifully you can explain such a difficult and complex syndrome. Many thanks for that. I want to put up one of our dear professors, Dr. Ali Madadi. He told us that he has a question. Dr. Ali Madadi, if you are with us. He is a pediatric gastroenterologist and one of our professors here in Children's Medical Center. Dr. Ali Madadi, we are with you.
Hi, dear Dr. Angarani. Can you hear me?
Yes, your voice is so clear.
Okay, hello. Hello to everybody. It's my honor that to be in this useful event. I'd like to thank you and dear Dr. Aghay and dear Dr. Me'mar and the others. I'd like to thank all the speakers, dear Dr. Navaiee, dear Dr. Arikan, and dear Dr. Dalia Bashir. I want to ask first from Dr. Bashir. In the last 2 years, we have an increased number of acute hepatitis and acute liver failure cases in our center that they have, some of them have a footprint of COVID-19, but not all of them. I'd like to know your experience about the COVID-19 and acute liver failure cases in your center in the last 2 years. Dear Dr. Bashir.
Dear Professor Ali Madadi, I think Dr. Bashir left us for an ICU call, so I kindly ask dear Professor Arikan or dear Professor Navaiee to answer these questions, any of them who could possible.
Thank you. And another question is that I'd like to know your experience about the neonatal liver transplantation in your center and combined kidney and liver transplantation in children in your center.
Many thanks, dear Professor Ali Madadi. So one question, experience with COVID-19 in these years with hepatorenal syndrome and also the same time kidney and liver transplant in the country. Professor
Hi, Laura. Yes, I want to add something. Hello to all of our speakers in Houston. Very nice to meet you. I'm sure that it was very difficult for you to just open in a space in your very busy schedule for this meeting. So thank you very much. I want to add that Dr. Ali Madadi is also the head of the liver transplant in children in our university and works very hard night and day for these kids, and his team results in pediatric liver transplant is awesome in the region. So there are many experience that can be shared with two teams, and thank you very much. Sorry for interrupting your answers. Sorry.
Thank you, Dr.
I'm wondering if we should hear from Dr. Virk and then get back to these questions. That might actually give Dr. Bashir time to get back to answer some of the questions.
Sure.
I'm happy to visit the liver kidney transplantation at the end, but I think both my colleagues, both Dr. Bashir and Dr. Virk, are part of the liver ICU, and Dr. Navaiee is as well. So they have much better understanding with their finger on the pulse about being able to answer these questions. Especially, I'm intrigued about that COVID-19 question. So I'd like to hear about our team's response. Dr. Virk says, I can't turn my video on. I'm gonna turn it over to the moderators. I think Dr. Virk needs to be made co-host, maybe?
Yes, now it is corrected. Yes, so sorry for that, dear Professor.
No problem, thank you. I'm Manpreet Virk. I'm one of the pediatric intensivists here. Thank you for the question. So that's a very good question and interesting. We actually have not seen any COVID-19 related acute hepatitis so far. That being said, I mean, we're still, although our peaks have resolved, it's still in the middle of pandemic, and we'll be vigilant about it, but we haven't seen any specific to COVID-19. And then with regards to the double liver kidney transplant, yes, we have done a fair amount. They're usually the ones with metabolic diseases, the maple syrup urine diseases, and their outcomes so far have been good.
Many thanks.
Manpreet, if you don't mind, let me just pitch in for 1 minute. So the severe COVID related presentations we have seen have fallen under what we characterize as dysfunctional inflammation, which we treat with immune modulation, just like adults do. So we've actually gotten to use IL-1 receptor antagonists, steroids, sometimes directed monoclonal antibodies, and really treat these patients as if they have HLH and treat them with severe immunomodulation. So I think the part of the multi-organ dysfunction with liver failure that we see in them sort of blends into other organ dysfunction. We have not seen isolated hepatitis, but we certainly have seen liver dysfunction as part of multiple organ dysfunction, which is very common for us because we're an HLH center. So I don't really think it stood out as much, since it's a very frequent presentation to our ICU. But we have not really worked anybody up for liver transplantation. It would be a contraindication anyways with an acute infection. So it's very interesting to hear this perspective from you all. Anyways, I apologize for barging in on Dr. Virk's topic. I'm going to mute myself and turn off my
No, it's so good. It's wonderful to have such a nice discussion panel. I really enjoyed it as a little student of the old time. I want to give a big thank you to dear Professor Akcan. I know that how difficult it is to join a Congress team in a little and short time. It is a big honor and pleasure that you accept our invitation. Sizi çok seviyoruz hocam ve inşallah gelen programlarda da birlikte konuşuruz ve program yaparız. Again, thanks. As I want to use the time before going to the lecture, I want to introduce you our dear lecturer, Dr. Manpreet Kaur Virk. She is medical doctor, is a pediatric intensivist at Texas Children's Hospital and Baylor College of Medicine. She is also part of the liver ICU team. Her interests include management of liver failure and transplantation, as well as mechanical ventilation in critically ill patients. And also she will be speaking on the postoperative ICU care of the liver transplant patients. It's a big honor to have you, dear Professor Manpreet Virk, and we are here with you.
Thank you so much for the invitation, and also to Dr. Arikan for this opportunity to present at this forum. Now I will go ahead and screen share. Are you able to see my slides?
Yes, they are clear.
Okay, sounds good. Okay. So today I'll be talking about the ICU, particularly the post-operative care of the liver transplant patient. I have no disclosures, and most of the data that I will be showing is based on our collective experience of our group here at Texas Children's Hospital. The objectives of this talk are to describe pediatric liver transplant trends in the US and Texas Children's Hospital, and then to discuss ICU-based post-operative management of liver transplant. Now, I'll briefly talk about the liver transplant trends in the US. This slide shows the liver transplant candidates that have been waiting for liver transplant over the past couple of years, from 2008 to 2020. And as you can see, the highest number is in the age group less than 1, and then in 1 to 5 years of age. Now, this slide shows the actual liver transplant recipients in the US divided by age over the past couple of years. Again, same time group since 2008. And then the highest number is in the age group less than 1 year, and then the 1 to 5 years old. This slide actually shows the patient's survival post-liver transplant, about 5 years out of transplant. That's close to 90%, not yet 100%. This is our hospital. It's a major center for liver transplants in the country. This slide shows the growing number of liver transplants that we've done at Texas Children's Hospital since 1988, most recently to 40 transplants in the last year, which is year 2021. This slide actually shows the total number of transplants we've done so far, which is 689 pediatric liver transplants, and then broken down by the age group done at our center here at TCH. 166 in less than 1 year of age, and 264 in the age group 1 to 5 years of age. Now, I want to talk a little bit about the intraoperative phases of this orthotopic liver transplant. There are 3 different phases. First one being hepatectomy, where the risk of exsanguination and shock, as well as acid-base imbalance, is very high. Then there's the anhepatic phase, where there's removal of the native liver and implanting the graft, as well as completing the anastomoses. The last one is the neohepatic phase, where there's achieving hemostasis, as well as biliary reconstruction is completed. And this is the phase where there's high risk of reperfusion syndrome, as well as acidosis, hyperkalemia, and hypocalcemia. Now I'm going to talk a little bit about the systems-based postoperative care and challenges that we come across when we take care of these patients in the ICU. So the principles of care basically revolve around monitoring and maintaining graft function, paying meticulous attention to maintaining effective arterial blood volume in order to support graft integrity and function, monitoring fluid balance to prevent hypovolemia or fluid overload, and then early detection of organ dysfunction and complications. Now, when we're taking care of these patients who come to the ICU post-transplant, it's really a very fine balance between preventing fluid overload, but also making sure they're not intravascularly depleted, managing post-op bleeding versus not creating a prothrombotic state, and then taking care of post-op infections versus adequately immunosuppressing them. And then these patients are at high risk for requiring prolonged mechanical ventilation, prolonged need for hemodynamic and vasoactive support, as well as a prolonged need for renal replacement therapy. We do know at this point that the sicker the child is going into transplant, the sicker and the rockier the post-operative course is going to be. I'm going to talk about the challenges related to the respiratory system. Most of the children that come post-transplant are actually able to be extubated within 24 hours. However, there are some kids that have high risk factors for prolonged mechanical ventilation. And what are those? If they've preoperatively been intubated and mechanically ventilated for a long time, if they receive a large liver, as well as the risk for competitive abdomen, younger kids, especially the ones with a diagnosis of biliary atresia, if it's a repeat liver transplant, as well as a massive requirement for blood product infusions, and whether they've been in the hospital versus at home versus ICU. The sicker a kid going in, the sicker he or she is going to be post-transplant, and the longer the post-transplant recovery phase. If they've had a preoperative need for renal replacement therapy, total plasma exchange, or inotropes, and if there's been presence of or detection of cirrhotic cardiomyopathy preoperatively. Goals of mechanical ventilation for these patients are pretty much the same for any patient with acute severe respiratory failure, where our goal is to try to optimize oxygenation as well as ventilation, but also balance and prevent any ventilator-induced lung injury. Judicious use of PEEP is warranted to prevent further alveolar collapse. We do recommend limiting prolonged fully assisted mechanical ventilation in order to basically practice lung as well as diaphragm protective ventilation, and to start pressure support trials in an attempt to liberate them from mechanical ventilation early on. There are certain instances where abdominal paracentesis may be warranted, and these are kids that we come acrough who've had massive ascites, and now ventilating them on higher peak inspiratory pressures is only going to cause more harm than any benefit. And those are the kids with high, elevated peak inspiratory pressures, escalating PEEP requirement, and then unable to oxygenate and ventilate, as well as presence of abdominal compartment syndrome. These are the ones that we do choose to do a paracentesis on. Virk and al. Did a study where they looked at the post-op ascites development, and in their study, they saw that the median time to resolution was actually 28 days. So these are kids, especially the ones that fall into the high-risk category. We know that ascites isn't going to resolve today or tomorrow in a few days. We have to get them through the first couple of days, even weeks, until we support them with mechanical ventilation and finally liberate them as the ascites resolves. Now, this is our own experience here at Texas Children's, where we looked at 200 patients who received liver transplant from 2014 to 2019, and we looked at the incidence of prolonged mechanical ventilation, which was defined as being mechanically ventilated for more than 7 days. A quarter of them actually were prolonged mechanically ventilated, and 75% were actually extubated within 7 days. Out of the group that required prolonged mechanical ventilation, 14 required a tracheostomy, and out of this group, actually 80% were ultimately decannulated. Let's talk a little bit about the cardiovascular challenges that we come across. So the goal here is always to maintain oxygen delivery and to meet oxygen demand. We're very hypervigilant about any events that could potentially cause hypovolemia and hypotension and could further risk perfusion to this new graft. Most of our patients, especially the younger ones, will come back post-operatively with low-dose dopamine at 5 mics per kilo per minute. We avoid diuretics in the first 2 to 3 days. We use fluids judiciously, normal saline as well as 5% albumin boluses in order to maintain effective arterial blood volume. We avoid midazolam boluses for risk of dropping the systemic vascular resistance and further risking hypoperfusion to the graft. Stress steroids, particularly hydrocortisone, are used in patients with history of adrenal insufficiency or catecholamine-resistant shock. And then coming back to the abdominal paracentesis, that's reserved for select number of patients that we think would benefit from drainage of the peritoneal fluid. And then epinephrine and norepinephrine can be used also post-op in addition to dopamine, especially in cases with vasodilatory shock. Our goal is to avoid hypertension. However, in the short term, hypertension is well tolerated. It's related to high-dose steroids that are used post-operatively and needed post-operatively, also related to fluid overload, pain and agitation. And then we do at our center use a low-dose nicardipine infusion to help control the blood pressure. The key to taking care of these patients is to anticipate trouble, anticipate which patients are going to have a challenging post-operative course. And there are certain risk factors, specifically for patients who've had a pre-liver transplant multiple organ dysfunction syndrome, ones who've had a cirrhotic cardiomyopathy, if they've been hospitalized multiple times, if they have what we call a hostile abdomen, or if they've had multiple intraperitoneal bleed, intra-abdominal abscesses. These are patients that we know are going to require multiple organ support and have a rocky post-op course potentially. Then this is another syndrome that's actually been coined by the director of our liver ICU, Dr. Ayse. It's called the post-transplant slump, and we've noticed this post-operatively, where the patient may be doing okay the first 24 hours, and then come day 2 to 3 post-op, there's a massive, significant hemodynamic collapse requiring fluid resuscitation, as well as even vasoactive need. And it could be because the steroids are being weaned at that time. There's also a lot of fluid shifts and reaccumulation of fluid in the belly, and the ascites is probably getting worse. And then the effects of immunosuppression and infection also start to kick in. Now, sedation and analgesia in these patients must be titrated to that particular patient. Most of our patients that are extubated post-operatively are managed with IV acetaminophen as well as a morphine PCA. However, the patients that require multiple organ support are intubated, and they're managed with a continuous infusion of fentanyl as well as dexmedetomidine. We also post-operatively do use low-dose Versed. However, we're careful about using large dose of benzodiazepines for risk of dropping your SVR and risking hypoperfusion. And then there really needs to be a proactive approach to minimizing ICU-related delirium. As we know, it's been associated with prolonged mechanical ventilation, as well as a delayed time to extubation in these patients. I'm going to talk a little bit about close monitoring of nutrition and electrolytes, and our goal is to maintain adequate caloric intake as the body is recovering post-operatively after this large surgery. We typically keep them NPO in the first 1 to 2 days. We use dextrose-containing isotonic fluids. We monitor labs pretty frequently in the first 48 hours, about every 8 to 12 hours, and then daily. We look at liver function tests. We're also very diligent about maintaining the glucose in the 100 to 180 range, and often use an insulin, continuous infusion of insulin to maintain that goal. Our patients, it is routine in our center that they come back from the OR with nasojejunal tubes in order to facilitate transpyloric feeds in case they're unable to tolerate POs. We often use total parenteral nutrition to supplement nutritional intake in order to ensure about 2 grams per kilo per day of daily protein intake. I want to spend a little bit talking about the post-operative abdomen and then the other downstream challenges that we can have with that. Ascites post-orthotopic liver transplant is common. We've seen it in about 30% of our liver transplant patients. There are kids that are higher risk, specifically the ones who've had biliary atresia, the younger kids, the ones with preoperative portal hypertension, preoperative fluid overload and organ dysfunction, as well as pleural effusion. And like I mentioned earlier, the median time for this ascites to resolve is about 28 days. And then I'm going to go back to, it's always challenging when we're trying to decide whether we should do a paracentesis in these kids or not. And it's a case-to-case discussion. And depending on if all the support that we are putting them on is actually causing harm, meaning we're on higher peak inspiratory pressures, higher peak that's actually causing barotrauma, then those are the kids that we elect to tap them, including the ones that show signs of abdominal compartment syndrome with dropping urine output and elevated bladder pressures. Do we leave the catheter in or out? Some of these patients we have elected to leave the catheter in, especially depending on where they are in their course post-op, because we know it's not going to resolve. If they're early on, we have elected to leave a drain in and do a controlled drainage every 6 hours. And then we also tend to replace it with 25% albumin, replace at least quarter of the drain output with 25% albumin in order to basically support the patient's oncotic pressure. Now talking briefly about the kidneys, we're permissive with fluids in the first 48 hours with a diligent monitoring of urine output closely. Diuretics are used very cautiously, often started after the 2nd or the 3rd day. And the reason we're really careful is because of these rapid swings in blood pressure that can potentially cause perfusion to the graft and also cause slowing and increase a prothrombotic state in the vessels. Continuous infusion, typically of loop diuretics, specifically furosemide, is what we prefer at our institution so we can control the fluid balance more closely. And then we do tend to supplement with 25% albumin in order to augment diuretic response in patients who are hypoalbuminemic. We do check serum albumin levels along with the liver function test daily, and we'll keep the albumin level close to 3 and above. We would treat if there's any signs of organ dysfunction or pulmonary edema and fluids, and we monitor body weights regularly as well as a fluid overload percent daily. And some of the renal challenges is some patients will respond to diuretics. However, there are patients who will require post-operative renal replacement therapy. And the risk factors for those are if they required pre-liver transplant renal replacement therapy, patients with hepatorenal syndrome, if they've had massive fluid shifts or required intraoperative blood loss needing massive transfusions, if they've required prolonged preoperative antibiotics as well as diuretics, patients after a combined liver kidney transplant with renal insufficiency, patients with a hostile abdomen, whether it's graft failure, whether it's hepatic artery thrombosis, portal vein thrombosis, or a repeat transplant. We've also, multiple studies have shown that use of cidofovir for systemic adenovirus also increases the risk for needing renal replacement therapy. We do know in these patients that when the liver recovers after the transplant, the kidneys should typically recover. Now, I'm going to talk about the vascular complications and maintaining the graft. So the most dreaded complication that we worry about from the minute one of a liver transplant is hepatic artery thrombosis. It occurs in about 8% in pediatric liver transplants. And the risk factors for those are patients that have smaller vessels, typically less than 3 millimeters, where there's abnormal arterial anatomy in the graft, which is requiring extensive reconstruction, need for multiple anastomoses, multiple transplants, or if it's a redo transplant, where the recipient to donor weight ratio is greater than 1.25, where the recipient is negative for CMV. At our institution, our hepatology group also found, as well as ICU group, that having a viral URI at the time of transplant actually puts them at a higher risk of hepatic artery thrombosis. And then patients with biliary atresia and the younger patients are at higher risk for hepatic artery thrombosis. The other dreaded complication is portal vein thrombosis, which occurs in about 3% of pediatric liver transplants. Higher risk factors for those who've had previous portal vein thrombus. Any condition that can cause hypotension or hypovolemia can actually allow for venous slowing and create a prothrombotic or a state where a thrombus could form. And multiple abdominal infections by way of causing endothelial dysfunction and further promoting thrombi formation, and potentially an underlying hypercoagulable state. A portal vein thrombus, though, with good hepatic artery flow is better tolerated than hepatic artery, given the dual supply. And then hepatic artery thrombosis is our worst nightmare. We always emphasize also to our trainees and team members that, we have to be very mindful from minute one to watch out and prevent any event that could potentially cause hypovolemia or hypotension. We're very judicious with fluids immediately in the postoperative stage. Platelets and cryoprecipitate are avoided as much as possible unless there's a life-threatening bleed. We avoid use of vasoconstrictors. We do anticoagulate at our center a select population, and these are usually the younger kids, or depending on the surgeon's experience in the OR, they will come back with a low-dose heparin drip, usually 10 units per kilo per hour. And these patients are eventually transitioned over to aspirin prophylaxis once you're able to tolerate enteral intake. We do surveillance with ultrasonography and Doppler in the first few days after the transplant, including watching your LFTs and coagulation parameters very carefully, watching for any signs of any clot formation. And then at our center for portal vein thrombosis, we have had a good success with our interventional radiology team in trying to recanalize the vein. And then adequate post-op antimicrobial prophylaxis is achieved typically with piperacillin, tazobactam, and vancomycin in the first 48 hours. And we do post-op prophylaxis against CMV, PGP, as well as fungal coverage with Bactrim and fluconazole and ganciclovir. Our immunosuppression protocol involves using tacrolimus and methylprednisolone postoperatively. Now, to summarize, liver failure and liver transplant patients can require multi-organ support. Patients requiring critical care services are particularly challenging. A multidisciplinary approach remains the cornerstone of excellent postoperative care in the intensive care unit, with a shared responsibility towards patient outcomes. And, here I have it takes a village to take care of a critically ill patient, definitely one who's received a transplant. So we have to thank all our patients and families, to all of you for this opportunity and time, as well as our entire critical care, renal, pheresis, extracorporeal liver support, transfusion medicine, and the entire team here at Texas Children's Hospital. And with that, I will stop screen share. Thank you.
Many thanks, dear professor, for your awesome lecture. Thanks for giving us your time and also sharing your knowledge. It was a great honor to have you between us. As may you will read in the chat section, Dr. Al-Madadi mentioned that in our center here in Children's Medical Center, we avoid using diuretics only in the first 24 hours post liver transplant. But you mentioned that you use it, I think.
So we avoid using them in the first 72 hours, yes. And then
yes.
after that, we monitor the fluid balance, and depending on if they're fluid overloaded, we would do a low, continuous, small dose of diuretic, typically a loop diuretic.
Very good. Thanks a lot. For this time, I pass the microphone to Dr. Aghaei, dear Dr. Aghaei. Again, thanks to all of lecturers. I pass to Dr. Aghaei and wait for some questions if they come up.
Thank you very much, Aylar. I would like to thank all of our speakers from Texas Children's Hospital. I know how busy your schedule is there. So my special thank and gratitude from Tehran to Houston, and special thanks to dear Dr. Ayse Akcan. Every year, I know she's very busy, but as a friend and as a good colleague, she helped us building this relation and keeping the relation alive. So thank you very much, Dr. Akcan. I know it's very difficult to get access to you, but you kindly and openly help us every year, and wish we will have you next year with us in Tehran. So there will be a chance. I hope for that I can meet you in person, and every speakers from your team will be welcome here in person in Tehran, maybe someday, very soon. So thank you very much again.
Again, yes, thanks a lot. Yes, it was a big pleasure, dear Dr. Akcan, dear Dr. Navaiee, and dear Dr. Bashir, and dear Dr. Virk. It was a great pleasure and great honor. Just before saying goodbye and finishing the session, just a question. They asked that you use low-dose dopamine anyway post-operation or only if needed. And then if nicardipine is not available for post-op hypertension, what is the next choice?
Thank you for the question. So yes, the low-dose dopamine is typically used in our younger patients, especially the ones who, if depending on the intra-op experience, if there's been difficult anastomosis, in order to maintain a slightly higher than normal systolic blood pressure and decrease any risk of hypoperfusion to the graft, but only in the younger patients. And it's typically discontinued after the first 24 hours after surgery. And then with regards to the second question, if another alternative to nicardipine could be nitroprusside, if that's available, in order to help control blood pressures.
Many thanks.
Do we have time to answer some of the questions in the chat, or do we need to wrap up? Are we running late?
Yes, why not? No, it's okay. We can have 10 minutes because our next session can start in 10 minutes. Of course, we have the next session's lecture, but it's okay. So go
Perfect. on. Dr. Virk, there is a question. It's asked 3 times. Neonatal liver transplantation. What is your experience? They're asking.
That's a great question. So far, I think it's depending on their anatomy and depending on the etiology of liver failure, we actually have not a whole lot of experience with neonatal liver transplant. And Dr. Arikan's been here and taught us a lot about what we know managing post-op liver transplant. And a lot of the recent neonatal fulminant liver failures that we've seen have actually been related to HLH and multi-organ failure, and which also precludes them from being a liver transplant candidate at the time.
Yeah, I will say our wait time for organs is very long. So in Texas, we actually have a little bit of a disadvantage in terms of being able to have access to appropriately sized grafts. So small patients, even if they do qualify with underlying disease process as indication for hepatic transplantation, we don't ever preclude them from transplantation based on their age. But the three most common things we see in the neonatal age is what we used to call neonatal hemochromatosis, which we now call GALD and treat with IVIG and plasma exchange. HLH, which we treat with immune suppression, and infectious related, mostly HSV. Sometimes it's multiviral, but mostly HSV, which we treat with antivirals. So if a patient truly has something else, or maybe HLH that is controlled with immune modulation, but still has led to severe graft dysfunction, they get listed. But the availability of organs is scarce, so it's not uncommon for them to wait for weeks on liver transplantation. And we're not very successful in that age group due to technical complications, and the hepatic artery thrombosis and everything else that is associated with post-transplant is much more common in that patient population. So Dr. Virk is right. We don't do it very frequently. We list them, but we rarely can get them to liver transplantation. HLH used to be a complete contraindication for us in the past, especially congenital HLH. And now that we understand it a little bit better, and the line between the liver disease, idiopathic liver disease, and HLH is somewhat blurred, we don't consider that an absolute contraindication. So we actually will consider those patients after their disease is in remission for potential transplantation. It's as you know, it takes a whole group, and they need to be presented to the medical review board, which is attended by our surgeons as well as our hepatology colleagues. So if there is specific patient level considerations, then we will evaluate those at the patient level, but we don't have sweeping contraindications to liver transplantation for age. It's challenging. The smaller they are, the more difficult it becomes.
Many thanks. So awesome description. Very good.
I think there was one more question about octreotide in post-liver transplant ascites. We have used it, unfortunately, with not much benefit post-liver transplant, but you know, it's one of the things that I don't hasn't been beneficial to us. So we've actually swayed away from using octreotide to manage post-liver transplant ascites.
And then, Manpreet, there is another question. So sorry, there's another question about the percentage of identification of a specific etiology in the acute liver failure population. I don't know if you know the most recent center numbers by heart, but.
No, but I can get back to you about that. Was definitely I can look into it. Yes.
Hepatitis is quite uncommon for us, as you guys probably know. We will have HHV6 and other sort of non-typical hepatitis viruses that present as etiology. A lot of what we considered idiopathic in the past and would transplant without a specific diagnosis turns out to be HLH. So we're actually in the process of starting a multi-center study. We're not the lead site, but we're participating in an NIH-funded trial where they're going to look at immune modulation with steroids and other immune suppressants for patients with idiopathic undetermined etiology for their acute liver failure, to see if there is a best regimen that we can actually potentially avoid transplantation with. So stay tuned. The more data is going to come in the next 5 years or so.
Good. Awesome. Thanks. Again, many thanks for your time, for your patience, for sharing your knowledge. The session was awesome. I learned much. I learned at the beginning kindness, patience, and also feel so honored and excited to have the chance of being in this session. Just regarding to my dear Professor Akcan and dear Dr. Navaiee, katıldığınız için çok teşekkür ederim. Sizi çok seviyoruz ve umarız bir gün kişisel görüşebiliriz.
Umarız.
If you have anything to say, dear lecturers, if you have anything to say before saying goodbye.
We just want to thank you. I'm going to thank on behalf of the group. And Dr. Navaiee did a lot of the planning, so he didn't get enough credit. But Dr. Navaiee did actually all of the work that you attributed to me. So thank you, Amir Jim. And this is such a great group of individuals to be with. We look forward to the invitation, and hopefully, once this pandemic is over, we'll get to connect in person as well. Thank you again.
Just I want to take a memorial screen, so keep smiling and keep your videos on and keep a steady to have a good picture of yourself. 1, 2, 3. 1 minute. Yes, go ahead.
And dear Professor Akcan, there are so many of our colleagues from Middle East also in this session. And for example, we have Dr. Asu, which is the head of the pediatric group in Iraqi Kurdistan. And there are so many other friends from Middle East. For example, we have friends from Lebanon, from Emirates, and also from Iraq and Jordan. So thanks to all of them for joining us, and thank you very much, all of our speakers, and have a good night and have a good day for you.
Thank you again.
Thank you all.
Thanks a lot. Thanks a lot.
Take care with love.
Bye-bye.
Dear audiences and dear participants, in less than 5 minutes, we are going to be with you with the session of cardiac transplant in pediatrics with the Hospital Gregorio Maranon from Madrid, Spain. I just want to share the flyer with you, and then we are going to announce the speakers.
La que modera es la misma, ¿no? Esa es la que tanto conmigo y no sé si como me da la tarde de hoy, no sé. A ver,